Good morning, everyone. I'm Russ Kino, Chief Medical Officer for Stasis Labs. I'm also the CMIO for Providence St. John's in Santa Monica and the Emergency Department Medical Director. I'm going to be talking to you today in conjunction with Dinesh Seemakurty, who is Chief Product Officer for Stasis Labs. And we're going to be covering trends in telehealth and the remote patient monitoring landscape. We've got three primary objectives for today's presentation: an overview of virtual care and the players in the remote patient monitoring field, to understand current reimbursement for RPM and the proposed changes that are shaping the market, and lastly, to learn how data can be leveraged for value-based care and population health. So just to get into the meat of this, the big question on everybody's mind right now is, given the whole COVID explosion in virtual care, will it contract? And what will that mean for all of us? Well, some examples here are that providers seem to be leading the way to drive value-based care along with payers. And three examples, firstly, Kaiser, some of the more traditional payers, launching virtual first health plans in various states. United Healthcare has announced they will be reimbursing all virtual visits not related to COVID, according to plan benefits. And some of the newer players like Oscar also launching no-cost virtual primary care. We all know that virtual care saves time, reduces costs, and increases flexibility for patients and clinicians. So the value proposition of virtual care, at least one of them, relates to virtual triage. In other words, helping us filter out patients who need an in-person visits versus the worried well. This virtual triage process, it ends up providing a lot more efficiency, which in turn lowers healthcare costs. This process of filtering patients who need in-person visits really helps with a proactive approach to patients, and we can remove the worried well during this sorting out process, which does two things. It removes the unnecessary exposure to COVID, which obviously everybody wants to do for both patients and practitioners. But it also saves patients time and hassle, as well as practitioners, for the cost and inconvenience of in-person visits. The common reasons for patients to be seen in a clinic currently or in the past have been things like ordering labs, dermatology consults, mild illnesses like UTIs, urinary tract infections, viral illnesses, and medication adjustment meetings, to name a few. All of these can be pushed off towards remote care and handled very easily in that environment. The growth in virtual care really spans telemedicine, acute visits, all the way to chronic care management. So if we think of one telemedicine visit as being a snapshot in time, where there's one acute problem and the patient gives the subjective story of what's ailing them to the doctor over the video chat, that can be reasonable in terms of giving the doctor enough data to make clinical decisions. However, the addition of objective vital signs through RPM, remote patient monitoring, would still be the underpinning of any medical consultation, especially if it requires some degree of complexity. And I do want to stress the fact that as a physician, and in particular in my role as an emergency room doctor, the collection of vital signs is foundational to any medical consultation in any environment. Doctors are taught to always pay close attention to the vital signs as the principal and, as I said, foundational basis of any medical consultation. In fact, for example, in emergency medicine, we are taught to never discharge a patient from the ER without double checking a last set of vital signs. In this COVID era especially, detection of abnormal vital signs like a low pulse oximetry could indicate quite severe and unnoticed COVID pneumonia, as evidenced by a low O2 saturation, for which the patient may be completely unaware. And similarly, for other disorders like blood clots in the lungs, etc., a rapid pulse rate may indicate something that is really amiss and that the patient ought not be discharged. So all the more when we're doing a remote consultation, if we can add some objective data like these vital signs, it's absolutely critical to the fidelity and quality of that interaction. Chronic care management is about trends in patient management. So it's the longitudinal progress of chronic diseases like COPD, diabetes, or congestive heart failure that becomes so important to track the progress of the disease. So if we can collect objective vital sign data over time and aggregate it, it helps tell the story of which direction the disease is going in. Is it deteriorating? Are things improving, or are they steady? And ultimately, virtual care will always be limited by the availability of objective data, which is so critical to any patient interaction. The overall landscape of RPM can be classified into three categories: there's software RPM, wearables, and traditional monitors. In the software RPM, you basically have software that integrates data from commoditized sensors into personal phones. With wearables, we have innovative hardware that measures vital signs essentially continuously. And with traditional monitors, we are familiar with them as being the gold standard monitoring technology for in-facility use cases like hospitals. So to take you further through this area, I'm going to hand it over to Dinesh. Dinesh, it's up to you.
Thank you so much for that, Russ. Really what we want to do in the next session here is understand what are these different categories and how are these markets moving. So the first market that we looked into in remote patient monitoring is the software segment. As Russ said, this is software that connects to commoditized sensors and delivers this data through a personal phone to the clinician. Now, if you look at the pros and cons of this segment, the pros are that you're really integrating cheaper and more cost-effective devices than hospital-grade sensors. And this offers patients and remote patient monitoring programs a lot of flexibility in picking and choosing their devices. Really, the focus here for these companies is focusing on the software functionality to review the data. But the same segment has a few cons. Some of these, as Russ was talking about, clinical care really requires the highest fidelity objective truths. And these solutions don't offer the gold standard trust required for real-time decision-making. In addition, we often hear that patients struggle with the idea that each of these devices often have different workflows, different charging, different instructions. And lastly, compliance to the program, actually ensuring the patient's constantly using the system, is really limited to phone calls of clinicians saying, hey, did you wear the sensor? It's notifications coming from apps, and it's really a high touch point activity to get compliance. When you look at the entire market and existing remote patient monitoring solutions in the software realm, really what we're seeing is that they honestly struggle to differentiate. They're really using hardware to differentiate, and most of them are using OEM devices that already exist in the market, and they're picking them up, connecting them using Bluetooth, and launching their program. Some of these vendors, like Vivify, will actually become our device agnostic, meaning that they support a myriad of hundreds of devices that are out there in the market today. But most of them are really using the same kind of software features across the board. We're talking about phone-based reminders, assistance and usage data for billing purposes. They include the hardware and they provide access to the data. So when we really look at this market segment, we're really thinking about how the quality of virtual care, the ability to deliver the best virtual care, is limited by the quality of the data source that these software RPM companies use. So they're really dependent on these external data sources, the OEM partners, the hardware partners that are out there today. We really see that this market is going to move towards the aggregation of the best devices that can drive the best care. And when we think about the best device for the patient, we're talking about a device that actually promotes patient engagement and ensures compliance. We're talking about a device that can actually offer clinical trust from both quality, reliability, and security. And lastly, all the data that we're creating has to continuously unlock insights so that clinicians can drive better care from a remote setting. When we look at the wearables market, the pros are very clear. We all think about wearables. We're hearing about them coming into the market, and it's really exciting to think about these wearables really changing how vital signs are collected. The pros here are that wearing a sensor is really the best way to get continuous data. As long as you're wearing the wearable, you're going to get data, and that's fantastic. And specific wearables are really great for patient comfort and compliance. If you're wearing a watch, you can wear that for quite a while. If you wear a patch, it's kind of behind your clothing. There's a lot of pros there. And the biggest pro is that this is the latest technology. We're going to see quite a bit of advances over the next few years. However, there's quite a few misconceptions when it comes to wearables, and these can be seen as limitations of their implementation in a setting like chronic care. For example, there's really no one patch or one device that can measure all the vital signs, which means that you may have to rely on multiple devices to get the information critical for that patient's medical needs. In addition, chronic care management is a lifelong battle. We're talking about months, years, multiple years. Honestly, very few wearables were built to endure that level of continuous wear. And we'll go into a little bit about wearable selection soon. And lastly, wearable data often needs validation from a gold standard sensor. Despite their accuracy, despite being cleared, they just have limitations. They have usage that clinicians are just not fully trained on and not fully comfortable with, which means that a reading from a wearable may often still require the access to a standard blood pressure cuff or some standard pulse oximeter to validate that reading. So when you look at the wearable market in whole, you realize that they're mostly differentiating on device type and the vital signs that they measure. By device type, we're talking about wearables such as chest patches, upper arm patches, wrist watches. Those are really kind of the core areas that these devices are being placed on a patient. A few insights here is that one, all wearables need to be charged. So you really have to think through how the wearable fits into the patient workflow. How often do they go put it on charge? How do they take it off? Or is it a disposable and they have to throw it away and get a new one? This can add cost, this can add workflow complications, and really needs to be considered again when you're thinking about a patient who might be on monitoring for months and years. The second insight here is that despite all the latest technology that's available, no wearable is currently FDA cleared for all the vital signs. You can see on this list that if you choose to make a wearable for blood oxygen, you tend to struggle with electrocardiogram and vice versa. Few wearables can successfully do blood pressure continuously, and even those come with some constraints and limitations. All of this ends up creating some complex questions that clinicians need to ask when they're using wearables for remote patient monitoring. For example, which wearable should you even prescribe? When you think about wearable use criteria, you realize that you need to understand what are the medical necessities which determine the vital signs that need to be captured, and how will those necessities for that patient change over time? Today, they may only need blood oxygen monitoring, but maybe in 6 months or 1 year, you also want them to be monitored for blood pressure. And so how do these wearables fit in? On top of that, patients have preferences and usability requirements. Some of them might have sensitive skin. Some of them might not want to wear a watch because they're already wearing a watch. So how do those fit into the entire workflow of prescribing this medical device? And so really for providers, what they have to think through for wearables is, how do you work with multiple wearables? You're going to need them to meet all your patients' needs. So really where we see this market going is that wearables are going to need to consolidate. There might be an integration layer that really meets these patient needs, and providers may have to pick and choose what they want to use. Another area that we see wearables moving is them doubling down on short-term continuous monitoring. We say this because really the device type determines the compliance. When you think about chronic care management, where this patient's needs to be monitored daily or every few times a week for years, really you have to have a wearable that can be worn for a long time. Now, the best category for this are your watches and your rings. Most smartwatch users like their watch and they wear them quite regularly. But wearing a smartwatch is quite different than wearing a medical wearable, and that needs to be considered. You only have two wrists. Watches and rings are great for long-term use, and patches really can struggle because you have to eventually take them off and they either need to be charged or disposed. How do you maintain this in a cost-effective way for such a long period of time? And lastly, can wearables really compete with consumer devices? As you can see here on the right, the Apple Watch recently announced an ability to measure blood oxygen. Now, it's important to note that only their heart rate and 1 lead ECG are FDA cleared, and their blood oxygen sensor does have limitations. But can they compete? Can a medical wearable compete for that same risk space? So what we see this market moving towards is really identifying specific acute events and then using that as a short-term analysis or short-term capture with high fidelity data, which can be used for escalation of care. And the last segment here is a traditional monitor segment. These are your bedside monitors that doctors and nurses know and they trust, and they have massively strong brand recognition, wide distribution, and most importantly, trust in the information that's coming out, trust in the objective truths. And what they will do in RPM is still unknown. These are large companies and they have a lot of opportunity here, and we haven't seen their direction in this new category. I want to now switch the conversation over to the economics of remote patient monitoring, because RPM is really, really, really new. In fact, CMS reimbursement actually only came into usability as of 2020. In 2019, these reimbursement codes were announced, but with a recent change in the incident to requirement, now clinicians don't have to be the ones that do the monitoring, but instead their nursing staff or technician can be the one reviewing the patient and escalating that to the physician. This is extremely important. Now, the 4 codes that you may have already known about, but we can go through really quickly, are the fundamental pillars of remote patient monitoring. You have 99453, which is for patient onboarding, which is a one-time fee of about $20. You have 99454, which is for the provision of the device and ensuring that data goes from the device to the cloud. This is every 30 days and can reimburse about $60. You have 457, which is for the actual 20 minutes review of the patient information. Again, billable every 30 days and and reimbursed about $50. And then a recent expansion has been 458, which now allows you to do more than 20 minutes of monitoring per month and billing an additional $40 every additional 20 minutes. And this landscape is constantly evolving. There's new CCM codes, TCM codes, rural codes that are allowing more and more physicians to practice remote medicine. And for clarity here, 500 patients can generate almost $1 million in new reimbursement revenue. So there's quite a bit of opportunity here. And all of this is delivered remotely to the patient, very cost effective for the physician group. However, RPM codes are continuing to mature. In 2021, there's already been discussions about how Medicare is going to loosen who can monitor patients, but it's tightening the technology involved in monitoring. A few key changes that we would like to share here is that 454 is now requiring devices to be medical devices defined by the FDA. And this is indicating a slow movement towards FDA clearance as being a requirement, which would really change what devices are currently being used in the patient household. This is, again, aligns to what Russ was saying about the objective truths involved in making clinical decisions. The FDA wants to ensure that those devices are clinical grade. So the second change that's coming up is that 454 will also require medical devices to actually upload the data automatically to the cloud without self-reporting, which means a patient looking at the data and typing it into a computerized system, or self-recording, where they have a device and they have to open the app so the app can connect and send the data. They want devices to work without any human interaction. And this is an important change, again, that might change remote patient monitoring programs. And lastly, 457 is now may require 20 minutes of synchronous video interaction and not just emails and messages, which can, again, change how RPM programs are deployed. So when you really look at this reimbursement and how reimbursement is moving, it's shaping the remote patient monitoring market and what is going to become virtual. Today, there's already an ongoing dialogue between the American Telemedicine Association and Medicare, where they're changing the business models, asking about different use cases and different implementations. So really, the business models from all these RPM companies are still being formalized. And secondarily, RPM is moving from just mere data collection to actual care delivery. Providers need the objective, reliable information for all their telemedicine visits to be based on. So overall, in reimbursement, RPM is currently fairly unregulated, but we should all be expecting that it's moving towards a more regulated future. Back to you, Russ.
Thanks, Dinesh. So I'm going to pick it up here and talk about value-based care. So value-based care, you may have heard about, really is synonymous with clinical outcomes. In the past, we've had fee-for-service medicine, which means physicians and other clinicians were paid based on their units of service for a patient. Medicare is moving away from that, and so are the payers. And what they're really interested in is just outcomes. Doesn't matter how much time you spend or what you do and what tests you get. It's really all about outcomes, which ultimately really makes sense because that's what matters. And so what really drives outcomes? Well, in this scenario of virtual care, there's really three principles. Firstly, the accuracy and reliability of the data. That means we can trust the way the data is captured. And obviously, as Dinesh was alluding to, previously verified methods, such as the traditional monitoring systems, are the most trusted by the medical community. Secondly, patient compliance, because at the end of the day, if they're not compliant, you're not going to have usability, you're not going to have data. So patient usability is key. And that obviously it means smooth hardware and software integration and ease of use for patients. And lastly, insights of longitudinal trends. As I alluded to before, these longitudinal trends give a real picture of the disease progression and management success. All of these factors assist in the proactive course correction, medication regimens, frequency of visits, and help us as providers get patients to the best outcomes. So ultimately, good data that we collect results in good decisions that we make, which results in good outcomes for patients, which is the goal for them and for clinicians alike. So how can RPM data be leveraged? Well, in the setting of one patient, the data that we collect through RPM can be a longitudinal view of the progress of that patient. However, in the setting of population health or many patients, data can be utilized as either a snapshot in time of a large number of patients and where things are at for them, or we can also take a longitudinal view of their care. And by comparing populations of trends, we can identify what's going on, for example, with how drugs are performing, look at the various outcomes based on different treatments, and we can build dynamic care plans on the fly. If you think about it historically, the way medical research and progress has occurred, it's been somebody does a study, they collect the data, and they publish it in a journal, and all of this takes maybe years to come to fruition, and then publication, and then slowly medical practice changes. Now we're going to be collecting this data on the fly in real time, seeing trends evolve before us and have those trends ongoing. So in a sense, we're going to be doing these studies in real time right before our eyes and be able to track and change management on the fly rather than having to wait for articles to come out in journals. But of course, there's going to be a lot of maturation that's required over that process. The point being, though, that we're going to have real-time data to track trends. So putting all of this together, we have the tech providers who provide RPM and a telemedicine platform, who provide the resources to the telehealth provider, who provides regular virtual visits and can track outcomes and escalate care. You have the physicians or other first-line providers who are continuing to provide normal service and deliver proactive actions to their chronic care patients. And you have Medicare, who's saving overall costs by reducing expensive escalated care that occurs in person. So we have this ecosystem with these various players in it for chronic care management and also for acute care management to some degree. But I think it's really in the arena of chronic care management where we're going to see the biggest changes and the biggest improvements. And it's also where there's huge expenditures. So in conclusion, we're going to run through a few points. Virtual care and RPM are here to stay. Value-based care is focused on outcomes and cost saving. This is a CMS holy grail. Medicare and payers are highly receptive and patient demand is high for virtual care. RPM increases the quality and fidelity of a virtual visit by providing objective clinical data, both in the moment as well as longitudinal. Ease of use of collecting this RPM vital signs translates to patient compliance, and trustworthiness of the RPM vital signs data is critical to being able to make decisions. Having this ability helps us as clinicians sort out who needs an in-person visit, and in doing so, minimizes clinic, ED visits, and hospitalizations. When we're able to do this, virtual care and RPM address the quadruple aim, which is improving care through improving safety and quality for patients, saving money for patients and the payers and the government ultimately, providing satisfaction and saving time for patients. It's also very satisfying for clinicians. And to a large extent, providing health equity to those who can get access to this, which is increasing every day, and improves the clinical experience for providers, which in this era of COVID stress and burnout, the fourth aim is actually providing a better experience for physicians and nurses and those who are providing care to our patients. With that, I'll hold it and open up for questions. Thank you very much.